And while we're actually going through bits, please do complete the poll and the quiz. Let's start to move into this so we don't take too much time out of everything else that we're doing. So I think first thing, let's get rid of this 7 o'clock because it's 7 o'clock now. Right. So our webinar series was focusing on history taking, physical examination, and pharmacy first. For those of you who don't know who I am, my name is Faheem. I'm a pharmacy prescriber, contractor, founder of MedLearn, and I've been teaching over 7 years pharmacists and various other healthcare professionals and how to develop your clinical skills. A big thank you to Locate a Locum for organizing this for us. Our vision is to help yourselves become better versions of yourself and enjoy what you do. And that's pretty much in a nutshell there. And again, Locate a Locum, thank you very much for being here. In our previous webinar, we started to discuss about the importance of conducting a rapid assessment. And anybody who was here last time, do you remember what I explained to you about A, B, C, D, E? Who attended the last session? And we explained this concept of A, B, C, D, E. So airways, breathing, consciousness, disability, and so on. So I'm not sure if any of you were actually here and were able to recall some of this information. Then we started to move on and we started to discuss this idea about recognizing signs of distress. And it's fairly straightforward, folks. Think of it when you are unwell. Think of it in your pharmacy practice. When you are unwell, what happens? Your signs, your symptoms, the color of your face, the way you're sat, your body language. So it's fairly straightforward, and we'll go quickly into that and just recap that quickly. And we also discussed about this concept of effectively engaging with patients, documentation. And now in today's webinar, I want to start to discuss the basics of inspecting the lips, oral mucosa, the tongue, and then quickly start to touch on the history taking, differential diagnosis for earache, and then we'll finish it in the next webinar itself. So we've got a lot to go through. Let me just move on to the next slide. And I will be giving you access to slides and so on. So in our previous webinar, we discussed this concept of starting with a rapid assessment. We spoke about airways, we spoke about breathing, we spoke about circulation. I mentioned consciousness, but circulation. We spoke about disability, and we spoke about this concept of making sure that you can also recognize exposure itself. So again, a brief overview. If you have someone who's sat in front of you, look for airway, look for breathing, look for circulation, look for disability and exposure. So what I mean by airway, have a look if they're using any of the accessory muscles. For example, if I'm sat here breathing like this, you can see these accessory muscles being used. And the muscles in particular that we're talking about are your, for example, scalene muscles, sternocleidomastoid muscles, pectoralis major, trapezius, and external intercostals. So keep that in mind. So that's again, you can have a look at that picture. We can see that this patient is unwell. Anybody who hasn't attended, this might be foreign to you. I will give you access to the recording. Don't worry about it. Just take my word for it for now so we can keep moving on. So I said, when you take on a patient and you're going to see your patients in your clinic, it's important to follow this concept here, where we observe always first. So when you're seeing your patients in pharmacy first, think of just looking at them and look at what sort of feelings are you getting? Would you say that this person is inherently unwell? That's the first thing I would say. When you're observing somebody, that's the first thing I would say is look at that patient and see, is this patient inherently unwell? That's all you're looking for, number one. Then we can go on in our examination and start to palpate. We'll discuss that later. Palpation means to touch. And we have to look at the system. So we have the respiratory system, cardiovascular system, abdominal system. We have the neuro system. We've got endocrinology as well. We've got dermatology. In some of these systems, we have to touch. And in the respiratory system, when we're feeling for the chest, we touch parts of the chest itself. When we examine the cardiovascular system, we also touch parts of the cardiovascular system. And this is the order that you just follow itself, okay? Regarding percussion, percussion is something that we're going to look into. Percussion is this concept of literally tapping. And we can tap on certain parts of our body itself to elicit a sound and see what's happening underneath. Let me give you a little test. Imagine you tap on a solid surface. What sort of sound will you get? Who can answer that question here today? So Abigail or Alina, Amara, Angelina, anybody, if you tap on a solid surface, you can write it in the chat. What sort of sound do you get? A dull sound. Yes, a solid sound. Look at it yourself, right? Get your hands or your fingers and tap on your kneecap. Listen to that sound. Just tap on your kneecap, literally. And then do the same thing and tap on your chest. And to do this, get one finger, place it firm and do this. And you'll hear a different sound. That is what we're looking to do. What we can do is we can use our theoretical understanding and tap on certain surfaces to see what's behind it. For example, what did this sound to you like? What do you think? Does it sound solid or does it sound like actually it's not solid? What do you guys think? Maybe this sounds not too clear. This sound here. What do you think? Oh, you can't hear it. Okay, great. Okay, you can't hear it. My bad. Okay. Well, it's a hollow. It's actually got it's a hollow surface. It's not a solid surface. So just like when you tap on a wall, it's exactly the same thing. But we'll go into this later on in a lot of depth. I just want to explain the term. So observation. Whenever I say observation, I mean to look. When I say the word palpate, I mean to touch. Doesn't matter what it means at the moment, just understand the terminology itself. Percussion for you now means using sound to elicit, using sound to understand what is happening below. Let me give you an example. Right. This is my chest. There's my, well, that's not really my chest. Let me draw this for you. Right. This is my collarbone. This is my collarbone. It's a nice collarbone. And there's my chest. Okay. And on top of this, we're going to have ribs and we're going to have muscle. We're going to have tissue. Someone tell me, are your lungs a hollow structure filled with air or is it a solid structure? Lungs. Solid or filled with air? Correct. So lungs filled with air. Okay. Now, when you tap on the part of your chest that has the lungs underneath, we get a certain sound. When you percuss or tap on the chest where the lungs lie, is that spelled right? Is it L-Y-E? Lie below, we get a certain sound. Okay. Oh, is it L-I-E? Thank you. Right. Now tell me, if your lungs were filled with a solid tumor, what would happen to the sound? No longer air. There's an area of your lungs that's got a solid tumor, solid rock tumor. What will happen to the sound? Thank you. It will change. It will change. It will change. Less hollow. Exactly. Less hollow. It will change. That's my point. Be muted. Whatever you want to say. The answer is going to change. We don't have to go into the science of what's going to happen exactly. As long as you both understand that it's going to change. When you understand it's going to change, that's the main thing. That's the main thing. So as long as you understand that the sound is going to change, that's the main thing. Even if it's a big tumor or a small tumor, the main thing for you to understand is, okay, Faheem, what you've explained to me is this. If I have a structure and it's normal and I tap, it has a certain sound. When that structure starts to change, the sound will change. That's all you have to understand for now. As long as you understand that, that's okay. And then we can look into we can start to discuss later on how the sound changes. So as long as you understand this, we are absolutely in a good position. That's the main thing. Right, auscultation. What does the word auscultation mean? Auscultate. Auscultate. Auscultate basically means to use to listen, to use a stethoscope. It's the thing that doctors always have and pharmacists and nurses when they put it in chest. Yeah, to use a stethoscope. That's it. Everybody understands this. Perfect. Right, now we're all on the same page. So anybody who's missed will have to watch the previous webinars because we've got very limited time. I can't go back and explain everything I did. I'll give you access to the link and check the previous webinar. Right. Now, the first thing that we're going to recap quickly is we're going to go through our vitals. Anytime you have a patient, you should always take their vitals. We'll then look at the hands, what you're looking for in the hands. Then we'll look at the face, the skin, and then we'll move on to the ears itself, in particular, something important I want to address. Okay, right, everybody. All of you guys that are doing pharmacy first here, please tell me, for an adult, what is the usual heart rate for an adult? What is the heart rate? The usual heart rate. Note the word I use, the word usual. Please tell me the usual heart rate, the range. The range. What's the range? Who can tell me the range? Good. Perfect. And this is for adult, right? Okay. Normal, we are going to say is between 60 to 100 beats per minute. What if it's less than 60? What do we call it? Who can tell me? Less than 60. What's the terminology? Well done. Bradycardia. Great. If it's greater than 100, what do we call it? Amazing. Good. Finally, okay, perfect. We got this. Right. There's many conditions that can change the heart rate. For example, infections, dehydration, certain medication. You understand this? Good. Now, tell me the usual temperature range for an adult, the normal temperature. So wait, before you answer this, stop everyone. I want you to define these terms. For an adult, I want you to define normal. I would like a low-grade fever. I would like a moderate grade fever. I would like a high grade. I would go like hyperpyrexia. Now answer. First, the normal, what's the range? What are we talking about normal? The range. And remember, your body works at a range. It's not just one number. What's the range? Yeah, I would say 36.5 to about 37, 37.2, so on. Again, depending on the textbook that you use, a degree Celsius, of course, degrees Celsius. So degrees Celsius. Okay, what is a low-grade fever? Who can define a low-grade fever? A low-grade fever, very important. The range for a low-grade fever, the range. The low-grade fever range. Yep, I would say that we can do a low-grade fever. We can say anyone who is around 37.3 to about 38. Well done. Good. Perfect. Well done. High-grade fever. What's a high-grade fever? Perfect. And then when we're going to high, we're looking at 39.1 above, and hyperpyrexia is 41 degrees. Amazing, amazing. And we spoke about how you get a fever. If anybody was listening and didn't get bored, we spoke about this concept of your body producing stuff like interleukin 1, interleukin 6, these inflammatory markers, TNF, tumor necrosis factor. These will go on to stimulate prostaglandins E2, and that will then change the hypothalamic set point. And then you get a fever. but we don't need to worry about that too much. That's just, I think that's just me being difficult. Okay, right. Someone tell me, by the way, tell me something. When your heart rate increases, what happens to the body itself when the heart rate increases? When your heart rate increases, what happens to your heart rate? Sorry, when your temperature increases, what happens metabolically? Good. Good. Perfect. So I would say for every 1 degree raise, you end up getting about 10 to 12.5% increase in metabolic rate. Everything gets faster. So protein breakdown, increased oxygen demand, heart rate, respiratory, everything goes up. I think for every 1 degrees, a couple of breaths will increase. So it's normal. The normal physiological response when you have a fever is your heart rate increases. Write it down somewhere. It's normal. That is normal. That when you have a fever, your heart rate will increase. Okay? Good. O2 sats. Someone tell me what the normal O2 sat range is. Yep, anywhere between 95 to 100. We discussed this in depth later on. Good, we've discussed this already. Perfect. I'm really impressed. And quickly, respiratory rate. What's the normal respiratory rate for an adult? Normal rate for an adult. Good, 12 to 20. And if it's less than 12, it's called bradypnea. If it's greater than 20, it's called tachypnea. Well done. Great, good. For those of you who missed, if you can kindly send an email to contact@medlin.co.uk, my colleague Priya will give you access to the recording and so on. Anybody who's missed anything was a bit confused with what's going on, okay? In the previous videos. Right. Okay, when you have a patient, the first thing that we look at is the hands itself. When you see the first patient in the hands. And what you're looking for is generally someone's hands. Tell me, when you look at someone's hands, what sort of things can you determine? Just even without, forget a medical perspective. Tell me what's healthy and what's not healthy in hands. If you looked at somebody's hands, what do you lot feel is healthy or not healthy? Forget medical. If I looked at somebody's hands, what would tell you if this person is healthy or not healthy? Color. Thank you. Color. Color is the first one. Temperature. Color, temperature, pale. Exactly. So honestly, you look at someone's hands and you can say, right, do those hands look normal to me? You know, is it extremely cold for the temperature itself? Like, are they suffering Raynaud's syndrome? Are they extremely hot? Are they sweating? Are there deformities? Brilliant, brilliant, brilliant. And without going into too much depth, because we're going to revisit this again and again, I just came up with some suggestions here to show you. So you can look for things like certain lesions that can happen. Ocellar nodes, Janeway lesions. It doesn't matter what they are at the moment, but just remember that you can look for certain lesions itself. Okay? You can look for the hands and look at their palms, look for muscle wasting, look for redness, look for erythema, look for any scars, look for any deformities. Perfect. So you can see this quite straightforward, that when you start with somebody's hands, all you're going to look at their hands like this, and then you get them to look at their hands like this. That's it. You can check the temperature by using the backs of your hands. So there's back of my hand. I can check the temperature like this and like this. I can also check to see how good circulation is, because if I was to squeeze my nail, the pinkish color should come back within 2 seconds. So that's all you have to know now. And I've raised these pictures here to show you different kinds of things. So this is like a claw hand, where you can see it's like a claw their hand. That's because they have a deformity, the ulnar nerve. We've got muscle wasting, where you end up getting muscle wasting. People can have things like arthritis. So that's all for now. That's all I want to go through for now, that when you start to look at somebody, look at their hands. Get them to put their hands like this. Get them to turn their hands. And just have a look at basics. Have a look at if their hands sweaty. Do they look extremely, are they blue? Were they having problem with circulation? Is there issue with temperature when you touch? That's all. And we are going to revisit this again and again and again. So don't get too bogged down with this, okay? Again, there's other sort of things you can look for. Some of your colleagues mentioned clubbing. Some of your colleagues have got other things like paronychias, oncholysis, habit tick. Again, I'm going to leave the slides on there, which will explain all this in depth, so don't worry about it too much, okay? I just want to explain to you that there are certain aspects of people's hands that we can look at that suggest normal and not normal. You don't have to worry about it too much. I will give you all the slides later on. Again, looking at nails, we've got Terry's nails, Blue's nails, pittings, colonychias, nicotine, splinter hemorrhages. There's plenty of causes of why they happen, what they mean, but just know what normal is for now. And here's a list. I will give you all the slides. So once we move on to the hands, let's look at the face. Tell me certain characteristic faces. Anybody can tell me certain faces that tell you this is like genetically not normal. Tell me a face that we've all seen that's not genetically normal. Any ideas? Yeah, Down syndrome. I was thinking Down syndrome. Okay, miserable, definitely miserable. I'm telling you something, my face was actually miserable today. It was actually really miserable. So had you have seen my face, Susan, you would have said you've got a miserable face. Correct. Cushing's, dehydration, cleft palate. You're looking at Down syndrome. Correct. So let's have a look at some faces here. So acromalgic face, can you have this? Have you ever seen this face where you can see that they've got enlarged facial features? It's caused by excessive growth hormone, where everything is enlarged. Cyanosis face, where they end up getting bluing in the lips. Somebody mentioned Moon's face, we've got Cushing's face. Down syndrome is very, very characteristic for Down syndrome. And again, with the Moon's face, what's happening is that you're having prolonged exposure to high cortisol, and then you get Cushing's. And we've got the genetic disorder, where you end up getting a disorder chromosome number 21, and we have Down syndrome. Marfan syndrome, thyrotoxicosis, where you can see that the eyes are absolutely protruding and you get this characteristic face itself. So great. Again, what are we started with? So we start with the hands. We're looking generally at the hands. Do we see any deformities? Do we see any blueness? Do we see any lesions, rashes? We got the face, you look at the same. Is there a characteristic face? What else can we look at the face? Any ideas? When you look at somebody's face and they're unwell, what else can we look at? Any ideas? Color. Good. What else? Rash, sweatness. What about looking for paleness in the face? What about anemias? What about jaundice? How would I look for jaundice in somebody's face? Where would I look for jaundice? Where would I look for jaundice? Correct. Eyelids. Exactly. You guys, absolutely beautiful. What about if I was looking for anemias? Where would I look for anemias? Again, the eyes. Perfect. Again, if you're unsure, I will give you the slides. Just try to remember what you can, and you're going to have access to the slides and Drive. So don't worry about it. I'll upload it. Perfect. Again, I've written these for you. Cyanosis, color, jaundice, rashes, hydration, so forth. Amazing. Right, quickly moving on to the eyes. We've got anemias. Has anybody seen xanthelasmata, where you end up having like lipid deposits on the eyes? Anybody seen this? Good. Again, we can look at certain things here. We've got periorbital edema under the eyelids. We've got jaundice. Again, I'm going to give you the slides. Nothing rocket science here. The lips, the mouth. So you can see that you can get angular cheilitis, where you have deficiencies in vitamins. And you can see that you can get this rashes here. We can get this, what we call this petechia, where you end up having these red spots. We've got, again, certain, you can look at the gum for certain hygiene issues. So again, we can also expect the mouth and the lips itself. Again, just remember, you're looking for rashes, lumps, and bumps. And the tongue, you've got this black hair tongue itself. You've got smooth tongue itself. Again, there's various reasons why this can happen. Has anybody ever seen something like this black hairy tongue? It's basically when you end up having, it's basically when you end up having debris and bacteria that accumulate the tongue, and this causes discoloration. It looks like there's hair growing on there, but there's not hair on there actually. It just looks like that. Candida, you must have seen Candida. Candida's there. And then we have the smooth tongue itself as well. So again, the smooth tongue is something that looks quite smooth. And again, it's because of iron deficiency, folic acid deficiency, and so on. Yeah, bad oral hygiene, correct, correct. Right, this is the fun part. Let's move on to the ear now. So, brief recap. Right, whenever you see a patient, the first thing you will do is observe. What we're going to do, we're going to look for A, B, C, D, E. I've got a patient with an earache. He's sat in front of me. The first thing I will do is observe. I'm looking for his airway, his breathing, circulation, disability, exposure. What do I mean by airway? Is this guy sat there like this? Number one. Is his heart rate higher than usual? Number two, circulation. Does it look like he's having circulatory problems? Is he looking like he's going to shock? Disability. Can he make eye contact? Is he speaking with you? And then exposure, do you see any bleeding and so on? Then you're going to gather the vitals. You're going to gather the heart rate, respiratory rate, O2 sats, and then you could go, you got the temperature, and then you could get the capillary refill time and so on. Now, then I spoke to you in depth about history taking, and we discussed this in depth. There's videos I've made on there. I'll give you access to the drive. We went in a lot of depth in history taking, so we're not going to cover that today. Okay, we are going to spend the next 15 minutes to discuss the most important thing, that is your differentials for your earache. There's 124 people plus here today. Everybody tell me some differential for earache. Before you can even take a history, list me some differential for earache. This is the most important part of the webinar now. Tell me some differentials. List me one differential for earache. One thing that can cause an earache. Ear pain causes. Tell me. So you've got, so everybody listing, good. Let's have a look. We've got wax, we've got ear infection, we've got otitis media, gum infection, burst eardrum, trauma, outer infection, perforation, inflammatory, foreign body infection. Okay. Right. You've mentioned infection. You mentioned trauma. And all of you have mentioned referred pain. Anything else? I'm going to make a list and we're going to go through it together. Okay. Let's go through this together before we spend the next 50 minutes on it. This is the most important. This you can take a picture of. I think you should all take a picture of when we complete this. I think it's really important. This slide is very important. Right. Number one, I want to list otitis, acute otitis media, as a cause for earache. Number one. It's not the most important cause, but it's a cause. Number two, infective otitis externa. Because if you don't know your conditions, there is no point wasting time on history. It's just not going to work. Number three, boils, furnicles. Number four, trauma and foreign body. Five, throat problems. So tonsillitis, pharyngitis, quinsy, so on. TMJ, temporomandibular joint dysfunction. We'll go into these in depth. Dental abscess. Trigeminal neuralgia. We'll go through each one in depth, don't worry. Mastoiditis. Cervical. Spondylosis. Can't even remember myself. Cholesteatoma. Malignant disease. Right. Now, who is brave enough to discuss these conditions? And I'll tell you something that you should write down, how to learn each condition. Let me tell you how to learn each condition. Oops, apologies for the spelling. Right. This is how you need to remember your conditions. This is how. This is how. Each condition, you have to know the incidence. How common is it? What causes it? Bacterial, viral, inflammatory, whatever it is. How does sex affect the condition? How does geography affect the condition? How age affects the condition? The pathology, meaning what does happen? Macroscopic, what you can see. Microscopic is scientific and more related to cell biology. Signs, symptoms, prognosis, and then you can add treatment and differentials. This is how you need to know your conditions. And we can then share the history as well and so on. Okay. Is everybody clear on how we're going to learn these conditions and how you're going to spend time learning these conditions? Because a lot of students get confused when I ask them, talk to me about a condition. They don't know how to present a condition. That's how you present a condition. You know the incidence, you know the etiology, the sex, the geography, age. And interestingly enough, when you get a chance to, you finish this class, go and look at your CKS. It's actually broken down like this. When you look at the CKS, this is exactly how they break it down. They talk about the incidence, the etiology, sex, geography. That's how they break it down. So this is exactly how you're going to break it down. Right. Obviously, we don't have time to discuss every condition like this, but I want to just talk about the first few. Okay. First of all, tell me acute otitis media. Who can tell me what sort of age range this condition is common in? What sort of age range? Acute otitis media. Okay. So this condition is very common in children who are below the age of normally 5 years. So less than 5. Okay, what's the practical implication? If you've got a child with earache and he's less than 5, then acute otitis media should be coming to your mind. Who can tell me what causes acute otitis media? What is the cause for acute otitis media? Yep. So the cause is viral and bacterial. And we're not going to go into the actual virus and bacteria today. We can discuss that later on. But viral and bacterial. Does anybody have any understanding of how sex can affect the condition? Has anybody done any research where we find that boys get it more than women or boys get it more than girls? Anybody have any ideas on this? I couldn't really find much. I believe it's very similar, but I couldn't find much. So Susan, if you've got a reference for it for the next class, that'd be great. If girls have it more, but I couldn't find much. So the reason why gender matters is because certain conditions are more common in women than men for various reasons. For example, a UTI. Which sex commonly gets UTIs more, men or women? Female. Why? Because they have a shorter urethra. So if you've got a patient who has similar, you've got a male and a female, both have similar symptoms, the UTI, you're definitely going to see it more common in women than men. Maybe because of genetics, because of women may have slightly more predisposition to ear problems than men or vice versa. I don't know. I'm not saying that there's a genetic predisposition. I'm not saying that there's a genetic predisposition that puts a woman more at risk than a man. I just asked the question if anybody knew anything. That's all. So I'm not aware of any differences, but there may be. And sometimes we don't have answers to everything. And there may be that men are more likely than women or women. I don't know at the top of my head. But you can certainly find out. And if anybody does find out, then do share the reference. It'll be interesting to have a look where it might be. And remember, it's not just anatomy. There's genetics. There's many other things that play a big wider. What we know is very top level, but there's obviously differences between men and women, and our genetics, our genes, everything changes. So again, it could be that. Right. Okay. So let's talk about the geography. I would say that children who are at risk or at exposure to day centers, people who have colds and flus, smoking are at more risk of developing acute otitis media. Why is that true? Anybody can answer it. Why does putting you at daycare centers, smoking put you at more risk of developing access to acute otitis media? Any ideas? Anybody could think about why, if you've got a child who is in daycare centers, correct, well done, absolutely. Exposure, well done. Vince, well done. Deborah, well done, good. Exposure to others. Because if this is a viral or bacterial infection, you've got to get it from somewhere. And close contact means that you can spread it more easily. Absolutely beautiful, perfect, that's correct. Good, you've got that. Smoking, again, if you're smoking, it can impair the cilia, the tiny hair structure that can put you at risk as well. Do you know that breastfed children are less likely to develop acute otitis media than those who are bottle fed? Did anybody know that? Breastfed are less than bottle fed? Good. And if you're unsure, you can research it, you can do some homework and find out why. Great. Perfect. Pathology. So let's talk about the symptoms. What does happen to somebody with acute otitis media? Any ideas? What sort of symptoms do you get with acute otitis media? What are the symptoms? So we get pain. We get fever. We get children pulling on the ear. Good. We get the tympanic membrane, we'll discuss later on, the eardrum becomes inflamed. We have discharge. And then you have children just generally, for children, they're not eating much, the children are just off. So they might not be eating, drinking too much and so on. Great, perfect, brilliant. Now, obviously, we've already nearly covered the hour. Let's put this in perspective. Let's compare this to otitis externa. Right, incidence. Which sort of age range is otitis externa more common in? Adults or babies? Who gets more risk of otitis externa? Older adults or babies? Correct. So again, you can see that if you have an adult or older children who have earache, you're looking more towards otitis externa than otitis media. Okay, someone tell me the risk factors for otitis externa. Risk factors. What puts you at risk? Swimming. Good. Swimming is going to be a risk factor. Using hearing devices. If you have eczema. If you tend to put trauma, cotton buds. Psoriasis, for example, in the ears and that sort of thing. So swimming, hearing devices, eczema, trauma, foreign body, etc. Right. Can you see how you can compare and contrast the different conditions and how we can use this knowledge to see the differences? This is my point I wanted to highlight to you. This was what I wanted to highlight to you, how you learn your conditions. Can you see how we can, the same person, you've got two individuals with earaches, you can already see, actually, let me think about the risk factors. A child, if I have somebody less than 5, I'm thinking acute otitis media. If I've got adults, I'm thinking maybe it could be otitis externa. Let's look at risk factors. Are they swimmers? Are they using certain devices? Has there been trauma to the ear? Okay. And we've only got literally 5 minutes left. I want to quickly ask you a question. Tell me how the symptoms for acute otitis externa differ from otitis media. What are the key differences? What do you see in otitis media that you don't see in otitis externa? Any ideas? So let me clear this and I will write it for you down. So acute otitis media. 1, tympanic membrane is inflamed. You have fever, usually. You have the external, the ear canal, normal. Acute otitis externa, tympanic membrane not inflamed, usually. No fever, usually. Ear canal swollen and ear canal swollen and small amounts of discharge. If you had a break in your eardrum, would you have a lot of discharge or small amounts of discharge? What would the discharge be like? A lot or small? Yes. There would be, I won't say a lot of discharge, but more, greater discharge. And then eventually pain disappears. The reason you get the discharge is because if I draw it for you to explain, there's my ear. Here is the tympanic membrane. Imagine you have all this fluid pushing here, pushing behind here. What will happen to the tympanic membrane? If all this fluid is something like this, it's pushing behind, what's going to happen? It's going to get red, it's going to get painful, and then when it bursts, everything will come out, the pain decreases, and then you get discharge. That is not what you get with otitis externa. Otitis externa basically means inflammation of the outer ear. And remember, the ear can be divided into outer, inner, and outer, middle, inner. Right. For now, why do you think I wanted to give you a list of differentials first before we go into the history? Why did I not just teach you, let's take a history in an ear? Why did I say that you have to know these differentials, or at least know a list before we go any further? Why was I adamant for you to know this list? Why did I not just say, okay, let's just go to the history, how they present? Why was I so important to give you a list? Anybody can answer. Why did I want you to know these differentials first, or at least know the list before we go to the history? Let me explain to you. Taking a history is just, yes, a history is just a interview. If you don't know what could be wrong with the person, even if you take an interview, what's the point taking the interview? It's not randomly going to come to your mind, is it? You're not going to randomly have some sort of, it could happen. You're not going to have some sort of God's intervention that, oh God, once I start asking these random questions, it's going to come to my mind. No, no. If I was to randomly start asking you questions without knowing what could be wrong, but having an idea, it's not going to work, is it? For example, let's say we did a class in neurology today, and you had no idea about neurology, but you could all take a history. You could ask about when it happened, how long you had the symptoms for, what's making it worse, what's making it better, so what? We can have a child follow a sheet and he can take a thorough history, but he won't know what to do with it. You guys are not going to be like this. You guys are going to be different. You know your conditions, that these are the conditions in the ear that I've got to keep in mind. Now, with these conditions in mind, I will now take a history. And as I gather my information, I can say, right, based on this, it could be this. Based on the information it's told me, it can't be this. Based on the risk factors, it may be this. Based on what they've told me, actually, it can't be this. Based on what he's mentioned, it's possible that it could actually be, it could be this. Actually, based on what he's told me, it can't be this, 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 it can't be this. I'm left with these conditions here. I'm left with this, and I'm left with this. Now I need to do an examination to differentiate between them, and there's your diagnosis. That is what we're going to be spending time in the next webinar in depth. We're going to look at all the conditions, how you take a history in the ear, how you differentiate between these conditions. So I know it can get quite long. I want to thank all of you for attending. Thank you for being here. I really appreciate it. For those of you who want to get in touch, there's the email address. You can get in touch with my contact, Priya, who can help you. I'll give you access to the drive as well. You can directly get in touch with us on our WhatsApp. Directly, you can WhatsApp us. Anybody who's struggling to develop their clinical skills, wants to find a DPP, or wants to expand their scope of practice and work in a general practice, whatever you might want to be, or open a private practice, get in touch with us. There are the details there. And I'll be putting the recordings out, or we'll be getting in touch with you directly as well. For those of you who haven't done the poll, please do the poll. I'll stay for a couple of minutes to answer any questions that you have. I'm more than happy to answer. You can write them in the chat or do them privately. I'll answer them for you. Please do finish the poll for those of you who haven't. And have a wonderful, wonderful evening. And this session is being recorded. So those of you who missed it, I will send the recording. Thank you very much. And I'll hang around for another 2-3 minutes to answer any questions that you might have. Otherwise, God bless you all. Great evening. And we'll meet you in a couple of weeks' time for the next set itself. Thank you very much.